All right, so this is section 4J. It's post-cardiac arrest treatment for adults and pediatrics. This is the protocol that we all hope that we can use on a regular basis. This is when you obtain ROSC in a cardiac arrest. So you look right here in the yellow box, your treatment priorities. Number 1, support oxygenation ventilation, avoid hyperventilation, avoid hyperoxemia when possible. Number 2, identify and treat underlying causes of cardiopulmonary arrest. Number 3, achieve a systolic blood pressure of greater than 100 using cold saline or vasopressor infusion. Number 4, initiate therapeutic-induced hypothermia if applicable, and the receiving hospital must have capability for the same treatment. So right underneath that, it talks about the inclusion criteria for induction of hypothermia. This is very important to know. This is a box that you will want to memorize, not only for testing purposes, but for real life, because instead of having to pull up a protocol and wasting time, it's just better to know this from memorization. So your inclusion criteria for induction of hypothermia, it is equal to or greater than 18 years of age, your return of spontaneous circulation, non-traumatic cardiac arrest, supraglottic or intubation airway in place, and no purposeful response to pain. So if something is on there that, or if you see on a test or anything like that, something else that's not listed in this blue box, it is not one of the inclusion criterias. But you have to have this stuff right here for induction of hypothermia. So again, 18 years of age or older, and you have to have ROSC. That one should be pretty simple. You're not going to start hypothermia protocol if you don't obtain ROSC, because they'll still be in cardiac arrest. This one is the one I feel like sometimes people trip up on. It's non-traumatic cardiac arrest. So if it is a cardiac arrest caused by trauma, this is not included in the criteria for the induction of hypothermia. You have to have an airway in place, whether that be a supraglottic airway or intubation. So for our sake, it's going to be iGel or intubation. You have to have one of those two in place to start your hypothermia protocol. And then the last thing, again, no purposeful response to pain. So we scroll down here to the EMR EMT box. It's just your general supportive care, vital signs, O2, cardiac monitor, and 12 lead. If the patient meets criteria for induced hypothermia, expose the patient, cover with a sheet, and then pack the axilla and groin with ice cold packs. For EMT license or higher, measure end-tidal CO2 and monitor waveform capnography. Place supraglottic airway only if indicated and BVM ventilations are ineffective. And then for EMTs advanced, intubate if indicated. If the patient meets criteria for induced hypothermia, it will be IV, IO, cold, normal saline. It's going to be 4 degrees Celsius. Also very important to know. 4 degrees Celsius, normal saline, 30 milliliters per kilogram, bolus up to 1 liter if there's no signs of pulmonary edema. So if you're going to induce the hypothermia protocol, it's going to be cold saline, IV or IO, and it's going to be at 4 degrees Celsius, and the dose for this is 30 milliliters per kilogram. I feel like the last several tests we've had, people trip up on the 20 milliliters per kilogram versus the 30. If you remember, the 20 is going to be your pediatric back a couple protocols ago, but it's not talking about induced hypothermia. The 30 milliliters per kilogram is for induced hypothermia with saline that's 4 degrees Celsius. So going down just a little bit farther, the paramedic box, medication-assisted intubation if indicated, interpret ECG 12 lead, ECG treat per protocol 5C acute coronary syndrome and or dysrhythmia protocols as applicable. Achieve a systolic blood pressure of minimum of 100 for IV fluid. Normal saline, may use cold saline up to 1 liter to achieve systolic blood pressure of 100 if no signs of pulmonary edema. Or you can use norepinephrine. A lot of people, at least when I was going through school, norepinephrine was it's also called Levophed, and they said Levophed, leave them dead, whatever. That's false. So Levophed works very well, and it's not hard to use. It's just a little bit different than other medications as far as how you're going to give it. Very, very good medication to use for your ROSC protocol. Levophed is going to be used more when you cannot get that blood pressure up to 100. So I like to say if the blood pressure's anywhere from like 88 up, try to get their blood pressure up with saline. But if it's not going up, then you probably going to have to try Levophed. Or if their blood pressure is very low, you can try the saline initially, but it's probably not going to work, and you're going to have to go with Levophed. Your Levophed dose is 2 to 4 micrograms per minute, IV push or IO push, and it's a bolus push. If for whatever reason we have a shortage on Levophed and we can't use it, we can use dopamine, and dopamine is 10 to 20 micrograms per kilogram per minute. And again, for both of those, this is only used if it's ineffective, or it's only used if fluid is ineffective or contraindicated. So an instance where it'd be contraindicated is if they have a history of congestive heart failure and they have pulmonary edema or anything like that, where we can't just give them a bunch of fluid. That's where we'd have to give the norepi or the dopamine. But a lot of the times, I say a lot of the times, some of the times, fluid's not going to get that blood pressure up to where we want it, so we're going to have to go to that norepi or dopamine. For pediatrics, you got to achieve a minimum systolic blood pressure of 70 plus 2 times age and years. IV fluid, and this is going to be the 20 milliliters per kilogram up to 60 milliliters per kilogram if there's no signs of pulmonary edema. If fluid isn't working for pediatrics, you have to call online medical control for any medication treatment or anything like that you want to do, and let them make that final decision. If the patient meets criteria for induced hypothermia for shivering control, paramedics, you can do Versed, and it's 0.1 milligram per kilogram with a max dose of 5, and then continuous assessment and treatment per applicable protocols. So just to recap on all this, you have your treatment priorities. You have your inclusion criteria for induction of hypothermia in this blue box right below the treatment priorities. EMR, EMT, it's pretty basic. Really the only thing for hypothermia is you're going to expose and cover and pack the axilla and groin with ice and cold packs. For advanced and intermediates, you can do the cold normal saline, which is 4 degrees Celsius, 30 milliliters per kilogram, if there's no signs of pulmonary edema. And then for paramedics, you have your medicated assisted intubation, and then you have your norepi and dopamine if you need it. And then for pediatrics, you're just giving normal saline, 20 milliliters per kilogram. So the only difference for pediatrics is the blood pressure, which we did talk about, which is 70 plus 2 times the years of age and years. We talked about that, I think, in section 1 a little bit, and then you'll see it mentioned a couple more times. So the key points are you want to achieve a systolic blood pressure of 100. If you're getting to that 98, 99 range with saline, you're probably safe. You just want to make sure that you continue to reassess your patient and make sure that they're not dropping. But that is it for post-cardiac arrest treatment for adult and pediatric.